Hello, hello, check. 1, 2, 3, check. I think we are getting ready for the next event. Check, check.
I have finalized with them, so he'll be coming.
Do you know what time?
6 o'clock, so he'll be on his way now. Like
Okay,
5 minutes before he'll be there.
so we can play the video now, or
මම ඩ්‍රයිව් කරන අමාරුයි.
මහන්සි නිකන්. එන්නයි යන්නයි ඔය දෙකම එකට අහුණා. අනික සෙන්වල පාර එන්න ගියාම ඕල් යන්නේ
බස් කාර්යය හොඳ
Voice than I have. Hello everyone, we're going to start shortly. Could I ask everyone to come forward so we can be closer together and we can have a good conversation. So please come forward and take some seats to the front.
බයිලා වැඩනේ. අනික මේ ලොකු ලොකු හොටෙල් වල සේරම ඕගනයිස් කරනවා. බඩු නෑ අපිට.
බඩු නෑ කියන්නේ.
මට පෙරේදා මේ තියටර් එකෙන් දෙනවා සර් සිකුරාද දෙන්නේ. සර් අන්තිම 5 note roll ඉන්නේ කිව්වා. අන්තිම සර් දෙන්නේ. ඔය ජෙනරල් සර්ජන්ට මේව නෑ ස්විච් මේව නෑ. සේරම ඉන්ඩිකේටර් නූල් දාලා ඉවර වෙලා අන්තිම
කියලා වැඩන්නේ. ඇත්තටම බුද්ධික ලෙෆ්ට් එක ක්වොලිටි එකට ගන්න මෙටීරියල්ස් හොඳටම බලපාන. ඔව්. ඒ කියන්නේ උද සූචරකෙන් මහොත් එහෙම ඩෙෆිනිට්ලි තියෙනවා. දැන් අපි වයිට් කී කිව්වහම වයිට් කී එකෙන් සූචරක
when he comes we'll stop. We could do that.
or we can play it and then if he hasn't come at that
අනික ඩර්මල් සූචිකස දැන් not තුනක් දැම්ම නැත්තම් ගැලවෙන්නේ. not තුන දැම්මම රතන මේ වැඩි බල්ක්
ඒක තමයි හේතුව.
yang tidak menyenangkan, yang mereka gosipin itu hanya bilang, oh bapaknya udah kayak gitu, anaknya juga kayak gitu, bagaimana nanti kehidupannya untuk ke depan?
Sering deh, dia Rajib ini seperti bapak, nangis ini jak rumah, dia anak ibu, sudah bagian kau,
අශ්ව පොල් ගහෙන් බැහැලා තියෙනවා.
Setiap sekolah pagi itu semangat, nggak rasa takut. Sekarang tidak pernah diejek. Udah berani berkumpul, bermain, main bola, lomba. Pertama kali ikut lomba. Sebelumnya nggak pernah. Karena bibir belum dioperasi. Lega, bisa bersyukur. Setelah operasi, setelah sembuh, hasilnya juga bagus. Saya tahu dari operasi kedua juta itu dari Bu Endang. Saya rasa istimewa dan senang. Najib sebelum operasi dia nggak mau main dengan kami, lomba nggak mau, dan main bola nggak mau. Najib sudah setelah operasi dia mau bermain dengan kami. Yang kami suka dari Najib, suka bermain dan berlomba dan bermain bola dan ceria. Kami sering bermain dengan Najib.
Pertama kali Rajib masuk sekolah setelah operasi, terlihat anaknya begitu riang, ya, antusias. Bahkan dia sempat memperlihatkan bibirnya gitu. Bu, lihat udah bagus katanya ininya. Itu kebahagiaan tersendiri buat dia itu ya.
Kemarin tuh ketemu kamu nggak tak tegur loh, soalnya aku lupa. Kamu makin ganteng soalnya.
Ibu ada aja. Pokoknya setelah saya pulang dari operasi kemarin, semua tetangga itu pada berduyun-duyun, ada yang datang juga, ada yang ketemu di jalan. Terus bertanya, loh Pak, kamu kok sekarang berubah? Itu saya kaget kok, perubahannya jauh banget berbeda dari yang sebelumnya. Terus saya bilang, saya juga tidak menyangka kalau saya bisa seperti ini.
Saya merasa deg-degan melihat adik dan bapak dioperasi pertama kalinya di rumah sakit.
Cemas aku. Kemuncuk jauh tidak masuk tangannya. Dia sudah banyak umur anak. Doa ya Allah Tuhan dulu, sekolah anak selamat. Jadi uang, pakatnya tinggi. Kalau ada mampuan. Cita-cita saya ingin jadi tentara. Saya masa depan lebih cerah.
Kedepannya dia bisa lebih percaya diri, bisa lebih mandiri dengan adanya perubahan dari sebelumnya sumbing sekarang bagus, jadi PD-nya luar biasa gitu. Saya yakin dia bisa kedepannya bisa sukses.
Rajib itu adalah harapan saya dan tumpukan harapan untuk masa depan bagi kami gitu. Sebelumnya kita diam di pelosok ini ataupun di desa yang terpencil, kita merasa malu, yang nggak banyak orang, jadi kita itu selalu bisa menghindari kalau ada untuk bertanya, itu kan bagi saya malu. Tapi setelah saya operasi ini selesai dan juga pulih, untuk kehidupan saya nanti setelah kalau saya bisa mencari kehidupan baru, tinggal di provinsi lain ataupun di wilayah lain, mungkin saya nggak merasa tersisih lagi, dan juga untuk berteman dengan mereka biar lebih dekat, nggak merasa malu gitu kan. Saya nggak bisa menemui satu persatu orang-orang yang telah mengulurkan tangan. Saya bisa cuma mengucapkan ribuan terima kasih kepada mereka gitu. Oleh karena berkat uluran tangan mereka, akhirnya saya bisa hidup bahagia gitu.
Saya berterima kasih sama yang penyumbang. Bisa saya operasi sama Bapak. Bapak itu panutan, kerja keras, dan untuk tanggung jawab.
Itu saat Rajib lahir memang ada gosip-gosip yang tidak menyenangkan. Yang mereka gosipin itu hanya bilang, wah bapaknya udah kayak gitu, anaknya juga kayak gitu, bagaimana nanti kehidupannya untuk ke depan.
Sering leceh ya, dia Rajib ini seperti bapak nangis ini jak rumah, dia anak ibu, sudah bagian kau. Setiap sekolah pagi itu semangat, nggak rasa takut. Sekarang tidak pernah diejek. Udah berani berkumpul, bermain, main bola, lomba. Pertama kali ikut lomba. Sebelumnya nggak pernah, karena bibir belum dioperasi. Lega, bisa bersyukur. Setelah operasi, setelah sembuh, hasilnya juga bagus. Saya tahu dari operasi kedua juta itu dari Bu Endang. Saya rasa istimewa dan senang. Rajib sebelum operasi dia nggak mau main dengan kami, lomba nggak mau, dan main bola nggak mau. Rajib sudah setelah operasi dia mau bermain dengan kami. Yang kami suka dari Rajib, suka bermain dan berlomba dan bermain bola dan ceria. Kami sering
Good evening. We are just waiting for the arrival of the minister, who should be here in a few minutes. Bear with us, please, for the delay. Thank you.
Riang, ya, antusias, bahkan dia sempat memperlihatkan bibirnya gitu. Bu, lihat, udah bagus katanya ininya. Itu kebahagiaan tersendiri buat dia gitu ya.
Kemarin tuh ketemu kamu nggak tak tegur loh, soalnya aku lupa. Kamu makin ganteng soalnya.
Gua ada aja. Pokoknya setelah saya pulang dari operasi kemarin, semua tetangga itu pada berduyun-duyun, ada yang datang juga, ada yang ketemu di jalan, terus bertanya, loh Pak, kamu kok sekarang berubah? Itu saya kaget kok, perubahannya jauh banget, berbeda dari
wants us to move to the other. Okay. Sorry. This one. Good evening. Those who are at the back, could you please come forward and sit? Because we are going to start. So, Honorable Dr. Nalinda Jati, sir, Minister of Health and Mass Media of Sri Lanka, esteemed guests, colleagues, and friends. On behalf of the World Federation of Societies of Anesthesiologists, it is my great pleasure to welcome you to this official side event of the 78th WHO Southeast Asia Regional Committee meeting. We are honored by the presence of each of you here. This evening, the session is on cleft to coverage. It is more than a panel discussion. It is a call to action. In a region that is home to nearly 1/4 of the world's children, access to safe and timely pediatric anesthesia and surgical care remains a critical gap in our journey toward universal health coverage. These gaps are not only clinical, they are systemic, shaped by workforce shortages, limited training in pediatric anesthesia and surgery, and fragmented health systems. But today, we focus on solutions. We spotlight cleft lip and palate care not only as a clinical priority, but as a strategic entry point for strengthening integrated emergency, critical, and operative services. Programs like those supported by Smile Train show us what's possible when national commitment meets global partnerships, leading to expanded access, empowered providers, and resilient systems that serve children better. World Federation of Societies of Anesthesiologists is proud to co-host this event alongside the Ministries of Health of Sri Lanka and India and Smile Train. WFSA is truly a global federation, representing over 500,000 anesthesiologists from 151 countries, including 10 national member societies in the Southeast Asian region. WFSA works to improve patient safety, expand access to safe anesthesia, and support national efforts to build resilient health systems worldwide. This evening, we'll hear from clinicians, policymakers, and partners who are driving change, from operating theaters to national frameworks. Their insights will help us better understand the opportunities ahead and how we can collectively advance pediatric anesthesia and surgical care across Southeast Asia. Let this be a space of collaboration, of learning, and of renewed commitment to the children of our region. Thank you for being here and for your dedication to advancing equitable anesthesia and surgical care. It is now my privilege to invite Honorable Dr. Nalinda Jati, Minister of Health and Mass Media of Sri Lanka, to deliver his keynote address. We thank you for your leadership and your unwavering commitment to health equity. The floor is yours, sir.
Thank you. Very good evening to all of you. Members of the head table, distinguished delegates, colleagues, partners, and friends. It's a great honor to address you today at this important side event on cleft to coverage, strengthening anesthesia and surgery for children in the Southeast Asian region. I extend my sincere appreciation to the World Federation of Societies of Anesthesiologists, Smile Train, and the WHO Southeast Asia Regional Office for convening this vital discussion. 1 in every 4 of the world's children lives in our region. This staggering figure reminds us of the scale of our responsibility and the opportunity we hold. As populations grow and more children survive early illnesses, the demand for pediatric surgical and anesthesia services continue to rise. Yet, many countries in Sierra still face critical gaps. Children living far from surgical facilities, hospitals lacking trained specialists, and operating theaters without essential medicines or monitoring tools. When a child cannot access life-saving or life-changing surgery, whether to correct a cleft lip, repair an injury, or treat an infection, the consequences are lifelong. Families bear emotional, social, and economic burdens that deepen inequality. To address this, we must strengthen our health systems in an integrated and sustainable way. To overcome the challenges, we must take an integrated approach to strengthening health systems. First, we must build and retain our anesthesiology and surgical workforce, the cornerstone of safe surgery. In Sri Lanka, we know the pain of cancelled operations due to a multitude of reasons. Sustained investment in training, mentorship, and recognition is essential alongside addressing brain drain, which drains both expertise and national investment. Second, we must improve access to essential medicines and life-saving equipment, anesthetic agents, blood products, and vital monitoring tools like pulse oximeters and capnography, which remain limited in many resource-constrained settings. Third, we must integrate emergency, critical, and operative care into strong primary health systems, ensuring continuity of care and resilience. Embedding anesthesia and surgical planning within national health strategies is vital. These policies must align with universal health coverage and workforce development to achieve lasting system-wide impact. We have made meaningful progress. Over the past decade, our Ministry of Health has expanded pediatric anesthesia and surgery through enhanced training, deployment of specialists to regional hospitals, and infrastructure upgrades. A major milestone has been the $107 million investment by the Asian Development Bank to modernize secondary health care, including surgical and anesthesia service for children. These achievements reflect the dedication of our healthcare professionals and the power of partnership. I wish to acknowledge the vital contributions of professional bodies such as the World Federation of Societies of Anesthesiologists, whose leadership in training, standards, and advocacy continues to elevate anesthesia care globally. Equally, SMILE Train's targeted support for pediatric surgery exemplified how strategic investment can drive broader system improvements. By aligning with national priorities, partners like WFSA and SMILE Train amplify our efforts toward universal health coverage. As we look ahead, let us remember anesthesia and surgical services are not in competition with other areas of healthcare. This is not a zero-sum game. Like the saying that a rising tide lifts all boats, when we strengthen these vital services, we lift the entire health system, and with it, the health, dignity, and futures of our children. Thank you.
Thank you, Honorable Dr. Nalinda Jayatissa, for that powerful and inspiring address. Your commitment to advancing equitable anesthesia and surgical care, especially for children, is deeply appreciated and sets the tone for the discussions ahead. With that spirit of partnership in collaboration, We now turn to our moderated panel discussion, where policy meets practice and diverse voices from clinicians, advocates, and decision makers come together to share insights and shape a better future for children's healthcare in Southeast Asia. It is now my pleasure to introduce our moderator for this evening's panel discussion, Dr. Vibhavadi Naik. Dr. Naik is a consultant anesthesiologist at Indo-American Cancer Hospital in Hyderabad, and her work spans from pediatric to oncological anesthesia. Please welcome Dr. Naik to the floor.
Am I audible? Yeah, right. Thank you, Dr. Kumudini, for the introduction. A very good evening to all. Ayubovan. Let me begin by saying that caring for the children of today is like caring for the world of tomorrow. And like we've heard earlier, a quarter of the world's children are living in Southeast Asian region. And when we say to achieve universal health coverage as a vision by WHO, I think prioritizing child care is very important. The good news is, with efforts from WHO and CRO, recent years has seen declining trends in infant mortality rates, even mortality rates in children less than 5 years. There has been increase in the rates of immunization, increasing accessibility. However, there is still lots of ground to be covered, particularly in the area of surgical services. Let me just put forth a little bit of data. Of those children with a surgical condition, more than half, depending on the region and the resources available, remain deprived. And given the large child populations in our region, this translates to millions of children with unmet surgical needs. This is the reason why we are here today, and this panel discussion will help us understand both the challenges as well as the opportunities in providing timely and safe surgical services for children in our Southeast Asian region. But before I begin, I have a small story to share. And this just happened yesterday while I was visiting one of the Smile Train partner centers that I have been mentoring right in the heart of India. This 30-bedded center is led by a surgeon, and over the last 2 years, we've been working with them over capacity building activities. So when I met him yesterday, I asked him how he feels about the changes that are happening in his setup. And he said, "Ek ki pragati se anek ki pragati." So let me just translate this for you. This means progress for one is progress for all. And he went on to describe how these changes have not just helped improve the cleft services, but have also improved other services. For example, his outreach activities are now capturing more children with other surgically correctable illnesses. The nursing training, the safety equipments that we have procured, and the protocols that we have set to enhance safety in the center are all translating to better care for all. This truly reflects the theme of this session, which is cleft to coverage, meaning, as mentioned earlier, how cleft surgery can be used as an entry point for a health system to strengthen access, build capacity, and provide safe, timely, and affordable wider pediatric surgical services. For this, we have a team of experts with us today, and we will begin. I invite Dr. Chamila Lianage, who is pediatric anesthesiologist at Lady Ridgeway Hospital, Colombo, and I request her to share the clinical realities of pediatric anesthesia in our region. Over to you, Dr. Chamila.
Good evening, distinguished guests, colleagues, ladies and gentlemen. My sincere thanks to the organizing committee for this opportunity. Today, I'll be speaking on clinical realities of pediatric anesthesia and surgery in Southeast Asia. Next slide, please. Next slide. When we look at the cleft lip and palate, the numbers already tell a powerful story. According to WHO, about 1 in every 1,000 babies worldwide is born with a cleft lip or palate. In Sri Lanka, although we do not yet have comprehensive national registry, provincial reports and regional trends suggest a higher rate, around 1.4 per 1,000 births. This highlights two key issues: the need for reliable local data, which should guide all the future planning, and also the scale of unmet surgical needs in our region. Cleft is visible, measurable, and most importantly, it's treatable. Yet a condition as correctable as this can go untreated for years, leading to feeding difficulties, speech problems, social stigma, and lifelong disadvantage. It also shows how improving cleft care can help build stronger pediatric surgical and anesthesia systems for all children. At Lady Ridgeway Hospital for Children, our National Referral Center, the multidisciplinary cleft team successfully manages around 300 cases per year. This mode can be expanded to other urgent conditions such as congenital heart diseases, neural tube defects, hydrocephalus, and anorectal malformations. In rapidly urbanizing countries, pediatric trauma is also a major cause of illness, demanding safe anesthesia and surgical support. Delays in surgery cost lives, hinder development, and burden families. Next slide, please. In my daily practice, I see these realities very clearly. We face a high burden of congenital anomalies and childhood diseases, many of which require timely surgery. Delayed access and equity gaps. Many children from rural and low-income families arrive late, often malnourished or with preventable complications. They cannot afford private care and wait the longest in the public system. Workforce shortages. In many hospitals, there are very few pediatric trained anesthetists and surgeons. This makes it difficult to sustain comprehensive programs even in capital cities and leads to long waiting lists for life-saving surgeries. Infrastructure gaps. Child-size equipment, ICUs, and recovery rooms are still limited. Training gaps. Many anesthesia providers have very few opportunities for continuing education, often due to lack of duty cover, funding, or structured programs. And perhaps most importantly, there's no national policies or follow-up systems to address these challenges or track progress. These are not only Sri Lanka's challenges, but also regional challenges shared across many low and middle income countries. Next slide, please. To strengthen pediatric anesthesia and surgery in Southeast Asia, we need focused and coordinated action. Even simple practical strategies can make a real difference. Invest in workforce, strengthening infrastructure, and promote equity to ensure that no child is left behind. Further, collaborate regionally, share expertise, use registries, and expand telementoring across Southeast Asia region countries. Leverage cleft program as entry points. Next slide, please. In conclusion, pediatric surgery and anesthesia are central to achieving universal health coverage in our region. We face undeniable challenges: workforce shortages, lack of policies and follow-up systems, delayed access, limited equipment, and inequities in care. Yet, there are clear opportunities. Our call to action is simple but urgent. Invest in workforce and infrastructure, integrate children's surgeries into national health plans, and scale up services to reach every child. Our vision is that every child in Southeast Asia receives safe, timely, affordable surgery from cleft lip to coverage and way beyond. Thank you.
Thank you, Dr. Shamila, for not just sharing the challenges, but also the opportunities that are available for us. And I would just leave you all to have questions for her. We have a dedicated question and answer session towards the end after all panelists have their presentations. And now we move on to the surgeon on our team. And for this, I invite Dr. Romesh Gunasekar, Consultant Plastic and Reconstructive Surgeon at Durdan's Hospital, Colombo, And I request Sir to share his thoughts on the need of multidisciplinary and integrated surgical care in children and how it affects outcomes. So over to you, Dr. Ramesh.
Thank you. Honorable Minister of Health, WHO representatives, and friends. Cleft lip and palate, as you know, realize, is a common congenital disorder. It's the commonest craniofacial disorder, and it has an incidence of about 500, and around, this was before COVID, every year, 500 live births every year. Though less in number than congenital heart disease, it's way more common than severe thalassemia. Now these children, next slide. These children, next slide please. These children will undergo at least 4 surgical procedures with specialized anesthetic care and probably many other ancillary procedures during their period of follow-up of 15 years at least. Now this is a significant treatment burden by many different specialties. Substandard treatment will lead to further treatment burden and of course lasting social disability. Therefore, a well-managed multidisciplinary cleft care system, use the acronym MDCC, is the only way forward for these kids. Next slide. I established the MDCC clinic in 2000 at the National Hospital Sri Lanka and later moved in 2003 to the Lade Ridgeway Hospital with the help of my orthodontic colleague, Dr. Sriyani Basnayaka. The team consisted, next slide please. The team consisted of a plastic surgeon, orthodontist, ENT surgeon, a pediatrician, speech therapist, a clinical geneticist, and a pediatric anesthesiologist, and an OMF surgeon. Now this is a big group. For 20 years, we were seeing 250 to 300 patients, and during this period, unfortunately, we had very little input from the center. We tried very hard to bring it to the notice. We wanted input from the center, and also we wanted to create a national cleft center, which never materialized. And it was obvious to me that there was very little insight as to the problem we were having with clefts. Next slide, please. Our team tried very hard. Now, bringing specialists together like this needs a lot of work. We needed to talk to everybody every morning. So we used to have 2 clinics a week, and we had to remind each clinician that we were expecting to see them in our clinic. And this happened purely because of the shared enthusiasm of 3 of us clinicians. Now, next slide, please. I would like to bring, now, the next slide, please. I would like to bring to your notice the type of involvement I would like to have for cleft services in this country. In the mid-1990s, in UK, the clinicians realized that they were not achieving the level of expertise and level of treatment that was prevalent in the rest of Europe. So they petitioned the UK government, and they established a clinical standards advisory group to study clefts. And after a 15-month study, in 1998, the UK government accepted the report. And in the recommendations, from 57 centers that were operating on clefts, they arrived at a figure of 8 to 15 centers at the maximum. Now this has led to improved management of clefts in the UK. And that is the type of involvement I would like to see for our cleft programs in this country. Because to keep the commitment of the clinicians, it's not enough for us to be just enthusiastic. It needs the support from our policymakers so that we can move forward. And I believe that Sri Lanka needs 6 to 8 centers, at the maximum, and so in the major teaching hospitals. And therefore, it has to be the commitment of the policy of the ministry so that they can direct the institutions to create the units so that we don't have to struggle so much to bring a fully fledged cleft team together. Next slide, please. This is the result of that sort of effect. Now, this is the North Thames unit, which I was part of, that gives rise to good cleft management. And I hope that is what we should be able to see in the future. Thank you.
Thank you for emphasizing that quality is much more important than quantity. And it's very important that not just that the surgery is done, but the child is rehabilitated, as I said, not just physically, but also psychologically and socially, so that the child can get back to the society as a normal, healthy child. But for this, we need stronger healthcare systems. And as we know, policy makers can significantly contribute to the direction in which the health system develops. So for this, I now invite Dr. Rajesh Khanna, Medical Officer at WHO CRO for Newborn, Child Health and Adolescents. And I request him to share how WHO and CRO are working with member states and non-state actors to strengthen the cleft as well as other pediatric surgical services. Over to you, sir.
Thank you, Dr. Naik. Honorable Minister of Health, esteemed panelists, and dear friends. It's wonderful to be here, and especially when we are talking of such an important topic, which is an emerging priority in the region. So what I have done in my presentation, I'll be talking a little bit of the burden. Is it actually a public health? Because my presentation will focus more from a public health perspective. How we can bring this movement, which has started in Sri Lanka, to cover the entire region. Second, I will move to, do we have enabling policy environment? And do we have enabling tools for us? Do we have the tools to support this? And thirdly, what role WHO and specifically the regional office can play in making sure that this movement, which starts from cleft lip, goes on to improve coverage, and then we achieve the universal health coverage. Next slide, please. Most importantly, do we have data? Is it actually a public health burden? Now, there was a Lancet report in 2015 which showed that it is approximately 2.5 million adults, they lack access to safe, timely surgical care. Following that, there was a bulletin of WHO publication which extrapolated the data and realized that close to 1.7 million were the children, and that included both children and adolescents till the age of 19 years. Thirdly was your Kids OR report, which further extrapolated. Now that brought into the focus that 87% of these cases are happening in low and middle income countries. And among those, it's your South Asia and the Sub-Saharan Africa, which bears the maximum brunt of problems. Now let's look into the causes. Now these are very important. Why? Because I will give you a rationale for why this is becoming more important as we move along. Most important are the congenital anomalies. I'm talking of the surgical needs as a whole, not only from cleft. Then the trauma, infections, birth complications, and tumors. The data that we are seeing from the regional burden of mortality, over the last 2 decades, congenital anomalies has emerged as the third most important cause of under 5 deaths. One important point. Birth asphyxia still remains the second most important cause, though we have been able to control deaths due to infections, pneumonia, diarrhea, we have been able to control. Trauma, one of the leading causes now emerging. So as your easily preventable causes we are able to control, it's your other causes, they start contributing more to the mortality burden. Next slide, please. Now, before I take you to two important resolutions that have been made at the World Health Assembly, where all the member states have committed, three important points. The region has been very successful in reducing. In fact, over the last 1 decade, Southeast Asia region has achieved the highest reduction in maternal newborn child mortality among all the WHO regions. Secondly, the aim is not only to ensure survival. There is a global strategy which outlines that the aim is to ensure the agenda of survive, thrive, and transform. That not only survival, but each child is able to reach its full potential and leaving no one behind. And the third is the reinvigorated focus on primary health care. Now, primary health care is the best platform to achieve universal health coverage. And I think the success story that we are seeing in Sri Lanka is all the result of its successful focus on primary health care as an approach to achieve UHC. All the countries which have been able to achieve UHC, primary health care has been the main approach. Now, two important resolutions. One was in 2015 on strengthening emergency and essential surgical care, which outlines the same. You do an assessment, identify the gaps, develop plans. So outlining all the actions need to be done. Now, following the Astana Declaration of 2018, another resolution which came last year, and this is where I think WFSA, Smile Train, and all the partners can really use this opportunity, is this 2024 resolution on integrated emergency, critical, and operative care. But again, the emphasis is, it's saying that don't do it vertically, integrate it into the primary healthcare approach. Please don't start doing vertically. All the words that we have used, multidisciplinary, early detection, all are taken care by this approach. Next slide, please. So these are the resources which I'm sure which you all will be aware of. So I will not spend time on it, but these are the various ones, and specifically the last one where WFSA has played a major role in bringing these standards for safe practice of anesthesia. Next slide, please. Now, coming to the role that WHO can play. Now, WHO, when I talk of WHO means WHO at the headquarters, regional level, and country level. And all have different role, but we are one organization. So usually your norms and guidances are developed at the headquarters level. And then they provide technical support to countries to convert these standards into national surgical plans. More importantly, evidence generation. Now, if you remember the first slide, we had some data, but unfortunately the data is not, it's based on estimates. We don't have reliable data on what is the burden of children who require surgery. That's an important part. And that is where I think WFSA can collaborate, and we can look into taking care of excellent registries wherever countries have registries and start generating data on it. Coming to the role what CRO can play. We already have a movement here starting today. Most importantly, providing technical assistance to countries. We know UHC is hot on agenda. If there is a 2022 commitment on primary health care, and everyone is utilizing that opportunity, why can't we start it with cleft lip and palate only? Can it be brought into the essential services for the government? This is a work that we can do together with partners. Very importantly, WHO is the only UN agency which has got a convening power. It can bring all different stakeholders together. Here we have a group of passionate pediatricians and anesthetists available, but we need multidisciplinary teams, as my friend has just shared. But that will not happen if you do it in isolation, unless the government takes the leadership, and this is where WHO can play that facilitating role. It can bring all the partners, community, civil society organizations all together, and we can look into what next steps can be taken. And most importantly, Sri Lanka's example again. All the other countries, if they can learn from your example of what you have successfully been able to do, like your PHC approach, now that's the platform that again is provided by WHO. We use it to share the best practices so that countries learn from each other. The challenges that you are having, the same challenges they don't face right from the onset. Of course, each country context is very different. We have to remember that. So the goal, my friends, remains the same. We ensure every child, whether needing cleft lip as a starting point or other surgery, has access to safe, timely, and affordable care through government-led systems and multi-stakeholder partnerships. Thank you.
Thank you, Dr. Rajesh, for emphasizing that pediatric surgical services are a priority and a significant burden too. And you've showed us the plans that WHO, specifically the regional office, has in mind for expanding them. I also like the idea that you suggested that cleft surgeries should be included as essential services. And probably we need to see how this can be taken forward. When it comes to cleft, we know that Smile Train has been doing incredible work for the last 2 decades. And it's important to have all the partners along collaborating when we want to achieve an important goal. And for this, I invite Ms. Renu for sharing the incredible work done by Smile Train in and around cleft surgeries. Over to you, Renu.
Thank you so much, Dr. Nayak. Good evening, everyone. Honorable Minister of Health, my dear colleagues and friends. It's an absolute privilege to share Smile Train's experience on how pediatric surgical and anesthesia services, particularly in cleft care, are essential to achieving universal health coverage in Southeast Asia. Next slide, please. Cleft care, as you know, is more than restoring a smile. It is a model of safe, sustainable surgical systems that we need to build to reach every child in need. Our work in India shows how focused investment in cleft surgery strengthens broader pediatric surgical services, improving outcomes for children. Next slide, please. In 25 years, Smile Train has supported over 750,000 cleft surgeries across India through its network of partner hospitals, which is currently 130 partner hospitals. These are mostly pediatric surgeries that require safe, specialized facilities and demonstrating a strong network of care nationwide. Next slide, please. The success of any program, and especially for us, the cleft care program in India, is a testament to the 3 pillars of the Smile Train Global Cleft Program. Next slide, please. Our program foundation resets and rests every day on these 3 pillars. The first one is empowering local medical teams via training, ensuring safety through rigorous standards, and fostering sustainable partnerships that build lasting surgical capacity. Next slide, please. As I said, that this cannot be done alone. We also have a very vast and very critical accreditation system for hospitals to come aboard Smile Train. pediatric cases, pediatric surgery, especially for cleft, is a very unique case, and they require definitely centers and infrastructure which can help these children get timely surgery. We help hospitals to build their capacity for safe pediatric surgery. So our Teach a Person to Fish strategy builds the entire multidisciplinary team skills, whether it is nutritionists, whether it is pediatricians, whether it is surgeon, anesthesiologists, speech services providers. Very important aspect in safe care is nurses and paramedics. So this approach enhances clinical excellence and local ownership for sustainability. Next slide, please. We cannot do it alone. Our collaborations with various stakeholders ensure that policies are aligned. We work with leading professional bodies, including the Federation of Obstetrics and Gynecological Society of India, NABH, the National Accreditation Board of Hospitals. These sort of collaborations reflect the power of multi-sectoral action. With FOGC, we have raised awareness amongst maternal and child health professionals for early cleft identification and referrals. Our work with NABH has helped improve cleft care protocols into hospital quality standards, reinforcing a culture of safety and accountability, which is very, very important. And we work very, very closely with the national and state health framework, including collaborations with the National Health Mission, programs like Rashtriya Bal Swasthya Karikram, because those programs are really targeted at the grassroots. They identify a case, they refer the child to the nearest Smile Train facility, ensuring that high impact care can align with broader child and public health goals. And we look forward to deepening our partnership and aligning with regional and global frameworks to ensure that every child, regardless of where they live, has access to the important care that they need. Thank you.
Thank you, Ms. Renu, for sharing the Smile Train work as the Area Director, South Asia Smile Train. And you've shared the strategies, and what I really like the most is empowering the teams. It's not just sponsoring surgery, it's empowering the teams, training them, and working on improving quality by partnering with various institutions. And I think that is where the broader safety in any procedures would lie. So with this, the floor is open for Q&A, and we would really appreciate if any of you have comments or questions to address to the team. I think we have a few online participants too, but they aren't able to participate in the chat function. Please, sir.
I'm Dr. Gayan Ekanayaka, plastic surgeon from National Hospital. I think I must congratulate Dr. Ramesh Gunasekara. He has done an enormous work of training us, and we do. I saw how difficult it was to build a system of multidisciplinary care team, and because I had to share his work when he left for quite a while, and it was an amazingly difficult task to do that. And because there is no office support, dedicated office support. There is some support, but not really institutionalized office support for the entire cleft multidisciplinary team. However, it still functions. It functions really well because the foundation is so solid with people who are interested in doing it. And we have tried to emulate that in different hospitals, but we are only there for 4 years. When we leave, the system collapses in some of the hospitals. So that's one area that a sustainable system has to be in place, as well as outreach programs, because these kids are, if they don't do the proper surgery first go, their social life is scarred forever. And the cleft surgery has evolved so much now. The techniques have not gone down to the grassroots level. So I agree with him that centers should be there to cater, because then the research and innovations can also take place in big cleft centers like ours, since we have started a lot of innovation, especially with operating with microscope, and we see the results are amazing. They are near normal. We hardly see the maxillary surgeries that are done earlier to correct their jaws due to malformation later on, purely because his techniques that he has taught us, and they have actually revolutionized these approaches that we do. So we are taking forward what he has taught us. So I think we just need the sound base to carry on, maybe some extended service to peripheral centers that we can offer, and we can actually ask him to supervise these systems if we can get these amazing personalities to emulate what they have done over a lot of years, maybe a quarter of a century together. So hopefully maybe a comment or even...
Sure. Thank you for your comment. And we can see that Dr. Ramesh has been an inspiring teacher for many sitting here. But I would want to highlight two things that he just brought about, sir. One is how can we make the system sustainable? And the second thing is regarding the outreach activities. So do you have any thoughts on either of them?
Yeah, I think one of the advantages that we have in Sri Lanka is that majority of patients have not far to go. So one of the ways I think, but one of the problems I used to see is the cost of getting to our services. Mm-hmm. And that is something that we need to address, and I'm sure the ministry would be interested in, and of course, that's another area where Smile Train can look at. Because if we encourage people, they are worried about coming because of the cost involved. So after we operate, they may not come for speech therapy. And we know we need speech therapy at least till 15 years. So this is where we need to strengthen the base to improve.
Yeah, sure.
And not necessarily go and do outreach surgery. I don't think that is very helpful.
Correct. Yeah, outreach surgery probably is not a good idea, and that's what even Smile Train does not recommend. But I really like the idea that because the surgeries are free by the ministry, but for the patients still, out-of-the-pocket expenses can be significant, as well as the family needs to dedicate time, which can also be a concern, and maybe Smile Train can be useful in those aspects. Thank you. I think there were some questions this side, please. Yeah. I think I would ask Sir to go in first because he was the first. Yeah.
Both of my questions basically stem from the video we saw before starting of this panel discussion. So I was just wondering, I just wanted to touch two aspects of this problem. First is the need factor, because in that video we saw two generations getting affected by the same problem, and one went on to have received that treatment. The other one could not, but given the right opportunity, he eventually managed to get that treatment. And the second approach was the child's experience and his problem with the illness was deeply related to his school environment. So my question is, what role do you think a school education department can play in reaching out to those children? And what role can health insurance, whether it is in PPP mode or whether it's government sponsored scheme, what role can it play in different countries? And as per your experience, how that strategy has been adopted in different countries. Thank you.
Sure, thank you for your, Dr. Yogesh, for your comment and question. Truly, the story of Aleem and Rajiv is touching, and it shows a gap that is being addressed over the years. Probably there is an improvement. And regarding the school networking, I would direct the question to Dr. Rajesh.
Okay, thank you for this question. Normally, when you're talking of cleft lip and palate, ideally, you don't have to wait till the child reaches the school. You know, if you have a strengthened systems in place, and by the time a child reaches the school and then gets operated, already some damage has been done, even though you try to control it. So developmentally, it could have a serious impact and further consequences on the family, the community. That's going. Now, when we talk of a systems, now suppose there's a late, and now, you know, if you come from India, you already know about the RBSK, which, so there you already have a mechanism. So ideally, you have frontline health workers going there. If they are not able to detect, then you have your, if they are able to detect, then you have your district early intervention centers. But the challenge is the lack of multidisciplinary teams out there. So when you don't have those teams, so what do those do? Then comes your insurance factor. Now you already have a government-sponsored insurance system in India. So that's a mechanism. I don't say, what I'm trying to say is, this, I'm not saying this is a flawless system. But what I'm saying is there are opportunities, but the challenge is how many people are utilizing this. You have policies, you have financial mechanisms, you have these things in countries, but how do you ensure its utilization? Secondly, school health services is now an integral component of the government systems. So they are also working. This has all been integrated into your RBSK program, the 4Ds that we call it.
Thank you. I think Renu wants to add in something because I know Smile Train does work with school teachers.
Yeah, exactly. First question for your need from the story. We find it really, really challenging, 25 years working in the field, yet to convince a parent to come and get the child surgery, which is very, very required to be done, is really where we need to still work upon. So a lot of awareness still needs to go. Number one, that it is treatable. They need to come on time, and we are working very, very closely again with the radiologists, with FOGC, with gynecologists, because that's the first touch point for a cleft child. The other aspects for school, you rightly said, because we see that emotional burden, a lot of bullying happens. So last year we launched an effort with the NCRT, and we are working very, very closely with the schools, government schools especially, and we have launched a series of storybooks where the stories of a child who's born with cleft is shared within the school, within the peers, and those books are available in the school library so that children can take it home, share it with their parents and things like that. So yes, definitely that, yeah. So we are working, and a lot of further efforts are required in this field. Thank you.
Thank you, Renu. Really happy to see all the work that Smile Train is doing beyond just sponsoring cleft surgery. But I think I've got an indication that we are running out of time. It's already 7. So we need to sum up the session here. May I quickly ask each of the panelists to give like one sentence take-home message, just one sentence. And I'm going to start with Renu.
Oh. Yeah, so my request to closing is to WHO, to our government's need for cleft registry, very, very important. Transforming care into empowerment, one smile at a time. Thank you.
Dr. Romesh?
Yeah, I must emphasize that we need to have a cleft registry, and we have to get it going quickly. And that's the only way we will know what we are dealing with and what we are not achieving.
Thank you. Dr. Kumudini?
I think we can, from the professional bodies, national professional bodies involvement in the region, can be increased to increase the attention we are paying for the congenitals, like the initiatives we are doing at the moment, the initiative we have done today. It will increase the awareness amongst the policymakers as well as amongst the professional bodies as well.
Sure, thank you. Would Honorable Minister want to say, give us a remark?
No, we have to do a lot anyway by our master plan, and I think we can do something with the next budget proposals, and we are going trying to allocate certain amount of allocations to start Dr. Ramesh activity to continue in the selected several centers.
Thank you. Thank you for your positive response. Dr. Rajesh.
Again, like to emphasize Ministry of Health-led multi-sectoral partnership, but second most important point to add will be keep child in the center of whatever you do. Make it a child-centered care.
Thank you. Dr. Chamila.
Yeah, my message will be a little different. So I think we need to start somewhere. So if we want to develop the system, so let's start with very simple measures like developing infrastructure, training, and workforce well-being.
Thank you. I would want to summarize by saying that when we are together, we are stronger. So we need to keep networking and collaborating to strengthen the pediatric anesthesia and surgical care in our region. And now I would hand over to Francis for the official thanking note.
Thank you. So I get the lovely job of thanking the organisers, speakers, and all of you, both online and in this room, for what has been, for me, a fascinating, timely, and important discussion on strengthening paediatric services in the Southeast Asia region. So I know from my experience, every year WFSA participates in the World Health Assembly, where we host well-attended side events. But what you quickly realise when you attend those side events is you often end up speaking and seeing the same faces at these events. Before you know, you've ended up almost into a surgical echo chamber. What I'm delighted with today is that I don't feel in this room that we are in that echo chamber. We have a wealth of committed, knowledgeable, and resourceful leaders in this room, representing a wide range of specialties. So my challenge to you for the remainder of this week and beyond is at the various sessions we attend, at the coffee breaks, at lunch queues, when we're down by the pool, speak to the country delegations and policymakers who aren't in this room tonight. My experience of working with policymakers is they don't just want you to bring the problems. They want you to bring the solutions to those problems. And from this conversation this evening, I think we've identified a number of those solutions. So I realise I stand in between you and dinner, so I will keep it short. But I'd like to sincerely thank the Minister of Health and Mass Media and his team led by Dr. Upuli for co-hosting this marvellous event. Our partners at Smile Train for their continued support. And the CRO teams, so those led by Rajesh, Shamila, Deepak, and many others, for their tireless work, expertise, and guidance. Finally, once again, I want to thank our panelists and speakers for their excellent presentations and for keeping to time, which something I'm clearly not managing. And finally, to all the participants in this room for making this such a thoughtful and fruitful conversation. So I know there's a number of dinner receptions happening tonight, so please, let's keep this conversation going. Thank you.
Thank you.